Oh, thank you. And everybody, thank you for listening in, signing up. If you Google the word unprecedented, you'll find that it's come up gazillion times. So these are unprecedented times. And we are doing a virtual meeting, which provides a lot of education, but it takes away from the personal interaction that we are all so used to. So in this world where we are socially distancing and, as people say, physically distancing, let's begin with the topic that was deemed to be interesting: irritable gut, which includes irritable bowel syndrome as well as irritable inflammatory bowel disease. Um, it's actually a bird's eye view of both these topics because each topic in itself would probably be 10 different lectures. So we will look at it from a top, and I'm not sure how many people were um, aware that today is National Take a Hike Day. And I'm trying to advance my slides. And Parminder, can you help me advance this?
Yes. Click in the other side, click over there.
Okay, there we go. Thank you. So it seemed like a sunny day, but it was awfully cold. So I'm not sure how many people did go out for a hike. Um, every time we do this, it's not the mountain we conquer, but ourselves. And that's a direct quote from Sir Edmund Hillary, who conquered Mount Everest. If we look at both irritable bowel syndrome and inflammatory bowel disease, there are several features that are common to both. And, GI being such an important organ, gastrointestinal system, we know that a lot of us have noticed changes in bowel habits, especially during this COVID times for a variety of reasons. Also, abdominal pain or stomach aches, upset stomachs, abdominal bloating, a lot of gas, mucus in the stool, mood disorders, anxiety, depression. There is bidirectional effect of the brain on the GI tract and vice versa of the GI tract on the brain. And both these entities have multifactorial etiology, which means there's several different factors that are known to be causative, but not one single way. If we look at hypothetically a response to infection, when you look at somebody, say, traveling, which again, doesn't happen that much in the last 7 months, but if you got infected from eating, say, chicken, or you got salmonella or something, you would have acute inflammation in the colon, and then the body could react in one of three ways. There would be either immune dysregulation, in which case, because of innate immunity, there's changes in the inflammation, and in a genetically susceptible person, you would end up with inflammatory bowel disease. In other patients, there might be just a sensitization, and that sensitization might cause mild inflammation maybe, or just hypersensitivity, which means the feeling is in excess of the amount of stimulus. And you might end up with irritable bowel syndrome. Most of the people, however, recover completely from this acute inflammation, and they are normal. There is neither IBS, irritable bowel syndrome, nor do they develop irritable inflammatory bowel disease. Similarly to infection, there can be changes in the colon microbiota, which are the bacteria within our colon, and the diet can make changes to these inflammatory changes. What are the differences between IBS, again, irritable bowel syndrome, and inflammatory bowel disease? IBS is a symptom-based diagnostic criteria, so there are several different symptoms that we base the diagnosis on. There are no accepted biomarkers, meaning there's no blood test or endoscopic finding that tells us that this is IBS. It just shows normal mucosa on colonoscopy. And there is a high prevalence. It's pretty common. 1 in 5 may have some form of irritable bowel syndrome. On the other hand, inflammatory bowel disease, the prevalence is far less, about 1%. And there is visible mucosal inflammation. So if this person had a colonoscopy, you would actually see some changes on the mucosa. We take biopsies and there's a pathologic diagnosis that's made. And there are certain markers like rise in the white count in your blood counts, increase in what's known as a C-reactive protein, or stool fecal calprotectin, or lactoferrin, which are markers for inflammation. Which is why sometimes there may be a misdiagnosis of IBS in certain IBD patients. So patients with inflammatory bowel disease may have such mild inflammation that they might be diagnosed as irritable bowel syndrome based upon the symptoms and the criteria. And IBS by itself is often ignored, and diagnosis is up for 3 years. So there's several differences between IBS and IBD. Also of note, almost a third of the IBD patients may report IBS-like symptoms, especially patients with Crohn's disease, more so than ulcerative colitis. And we know that there's increased IBS-like symptoms in patients with IBD that are in remission. So it's important to diagnose IBS in these patients because the treatment varies and you do not want to keep giving treatments that can cause more side effects to these patients. So how about the prevalence of IBS? Like I said, it's almost 1 in 5, and it appears to be more so in the developed countries than the developing countries. So some of the African countries, the prevalence is much lower, and usually it's higher in women than in men. I do not want to bore you with all the details of the diagnosis for IBS, but Rome 4, which classifies functional bowel disorders as IBS constipation, IBS diarrhea, IBS mixed, or functional bloating and distension, or opioid-induced bowel disorder, has specific criteria for the diagnosis. And you have the slide, so you can look at it and mark off if you believe that you have one of these. I have patients that do come in and tell me, I went on Google and Dr. Google told me that I had IBS. So, maybe you can say Dr. Chokhavatia's slide had these criteria, and therefore I think I have functional constipation or irritable bowel with constipation, or I have functional diarrhea. It's important to know what we base this diagnosis on. It's usually the stool form. So I'm hoping that nobody is actually at dinner and you're not using this session to be background to your dinner get together. We are talking about stool form, and not to gross you out, but it can be type 1 to type 7, and it's known as a Bristol stool scale, stool form scale. And patients that have small, hard lumps like nuts, some patients have called this sheep dropping, some have called it rat dropping, can have type 1, and it's correlated with constipation. Type 7 is what we call diarrhea, which is watery stool, and there are no solid pieces of stool. In between, you have a variety of different types that have been kind of described, and type 4 and 3 maybe are usually normal. These kind of connote diarrhea symptoms, and this connotes constipation symptoms. And the reason to know that is then you can diagnose either IBS-C, IBS-D, IBS mixed, or it is unspecified if you cannot get any of these. And the way to do this is to keep a stool diary and not to get too fixated upon your stool. But if you really feel you're constipated and it's just frequency that you're looking at, maybe looking at the stool form may help diagnose constipation or diarrhea. In addition to irritable bowel syndrome, there are several other functional GI diseases or disorders, and a lot of these can overlap. So you can have early satiety, which means you feel full very quickly. You can have nausea, vomiting, heartburn, belching, regurgitation, trouble swallowing, pain in the belly, which is discomfort most of the time, not sharp pain, which means there could be different things going on, spasms coming from the gas, constipation, diarrhea, and bloating. So all of these are symptoms that we ask patients for. In addition, in patients with IBS, there are extraintestinal comorbidities, which means they are not related to the GI tract. And a lot of these have to do with the brain because we talked about the brain-gut interaction. It can be anxiety, depression, panic disorders, other phobias, migraine, temporomandibular joint pain, fibromyalgia, chronic fatigue syndrome, chronic pelvic pain, chronic cystitis, sexual dysfunction, menstrual disorders, eating and sleep disorders, and something new that's been described with IBS patients. And this is known as avoidant restrictive food intake disorder. And usually this is noted when patients are very particular and they are so avoidant in the foods that they eat and so restrictive in their diet, they end up losing weight. And weight loss is sometimes something that we worry about it being IBD and not IBS. So we do ask for avoidant restrictive food disorder in patients that may come in with this. So we talked about IBS with a higher prevalence in younger women, a 4-fold increased risk after infectious diarrhea at 12 months. There can be a 2-fold increased risk if there's a history of adverse early life events. And usually this is seen in patients that are in the 20s and 30s, and they'll tell you that, oh, when I was a little child, it was very traumatic. You know, my parents separated. I hated going to school. There was a bully at school. And all kinds of different adverse events that occurred that then they would call in sick with pain in the belly, constipation, diarrhea, and then that kind of became a learned response. And then when they presented to the doctors, this is presenting as irritable bowel syndrome. Like I said, you know, it takes up to 3 years and sometimes up to 7 years for the diagnosis, because most of the patients do not seek health care. They think, oh, I was nervous. I had this important presentation coming up. That's why I had the pain. That's why I was feeling nauseous. That's why I had diarrhea. And I don't really need to see the doctor. So a lot of times symptoms are just relegated to secondary because there's so many more important things that are going on that need your attention. Children are staying home. They need to be homeschooled. You're taking care of your job and you're taking care of the children. You know, you're not going to worry about that little constipation or diarrhea till it becomes an issue and there's a lot of bloating and you say, okay, let's pick up the phone and let's see if we can do a telemedicine visit. So just so you know, you can do that and at least get somebody else to get a second look and an outside person weigh in on your symptoms, because the symptoms can be related with really poor health-related quality of life. And both the combined direct and indirect costs for management are exceed 1 billion. That's a billion. So the treatment that the doctors, usually the gastroenterologist, it focuses on the individual symptom of IBS. We tailor the treatment to individual patients, and it could be dietary treatment, pharmacologic treatment, or integrative treatment options. So again, it depends upon what the person is actually complaining about. It's important to know that none of these effectively treat every symptom. So everything needs a specific, kind of treatment modality. So you have to have a multi-pronged approach. And sometimes many interventions may exacerbate or increase the individual symptoms, such as if you're constipated and your doctor tells you to eat fiber, fiber then can cause bloating. So then your spasms go up. And then you take antispasmodics, and that can increase your constipation even more. So it's really important to look at every aspect of the symptom and every aspect of the treatment. One of the things that I usually ask patients to do is to, keep a diary. You don't have to really follow a low FODMAPs diet, which is really fermentable, oligo, di, mono carbs, as well as polyols. So these are all fermentable carbohydrates, and these can increase the amount of gas. So the foods that are okay are tomatoes, eggplants, carrots, spinach, zucchini. But remember, these are what the guidelines say, which is, not every patient has the same. Some people might come up and say, but I get increased gas when I eat kiwis or pineapples. So this is just a guide. And especially if you're not overweight, you do not want to follow specific diets because then you might come up with the RFID like we talked about. You just want to avoid those foods that can cause the symptoms. And if you notice that cauliflower, broccoli, mushrooms, onions, garlic cause increased gas, then you want to try and cut it out of your diet. You can also eat meats, but again, pay attention to what you're eating and keep a food diary and a symptom diary. Complementary alternative medicine, now known as integrative medicine, includes yoga, which I find a lot of my friends are doing every day. You can't go to the yoga studio, but you can definitely sign in, and you can do this on Zoom, which we are doing on Teams. You can do meditation, make sure your sleep habits are adequate, sleep hygiene. And I know you had a lecture yesterday on sleep, so maybe you can go back and see what that was all about, because I'm sure those are all out there and you can access those slides. Breathing exercises, probiotics, acupuncture, herbal and Chinese medicine, all the word of caution. Most of these medicines can cause liver issues, so do not, take too much of anything without consulting your physician, your doctor. And then holistic homeopathic medicine, the same thing. The most important thing is to educate and reassure yourself that this is a mind, body, or a brain gut issue. We are all under a lot of stress right now, so IBS symptoms will tend to flare. And as long as you're doing some of this, it might help to decrease the effect of the mind on the body or the brain on the gut. There are biopsychosocial factors that we know about and that can cause increased symptoms. We address assumptions, attitudes, and beliefs, and we always think positive. So we know we will come out of this. The vaccine is around the corner for COVID-19, and we know that there is light in that tunnel. The integrative treatments include cognitive behavioral therapy, or CBT. And usually, you have a therapist that tells you to keep symptom diaries, identify stress events, and they provide you with coping strategies. There's psychotherapy and interpersonal therapy, identifies relationship difficulties. Imagine being cooped up at home with everybody that you thought you loved. I had a patient who told me that their 13-year-old child went online and said, I love my homeroom teacher, but please, 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 for next year, can we change homeroom teachers? So we know that, there can be difficulties if you're staying home all the time. Use positive suggestion with hypnosis, mindfulness, relaxation training, and it stimulates relaxation, do stress management, and shift your focus from the pain to positive thinking. But mainly it's a patient-centered management in IBS. You need good patient-doctor communication, should be non-judgmental communication. Patient acknowledges and accepts the diagnosis and is an active participant in health literacy. The doctors acknowledge patients' symptoms, review the criteria that are diagnostic, acknowledge the severity and anxiety of the patient, discuss the coping mechanisms, address the lifestyle dietary changes, involve the patient in management decisions, and empower them so that there's a shared decision making and it's a joint venture. The patient wants to feel well, and I can tell you personally, the doctors want the patients to feel well. And we always look out for alarm symptoms or red flags, which indicate need for further testing. But remember, these are for other diagnoses, not to exclude IBS diagnosis. And what we're looking for is symptoms at night, unintentional weight loss, an older person like 70-year-old saying that now I have symptoms of pain and diarrhea. So it's not IBS new onset, but something may be going on. We look for family history, for cancer, for inflammatory bowel disease, ulcerative colitis, Crohn's disease, celiac disease, and if there's bright red blood per rectum, which is rectal bleeding. We look at if we can get the person into our offices, which the new offices are on 140 East Ridgewood Avenue. They're brand new, located right next to the new Valley Hospital, which is being built. And it's a huge office, very clean. If you do come in, if you have no restrictions, if you've not been exposed, haven't been out of the town or haven't been out of the country, the exam, we look at the belly exam, we do a rectal exam if it's needed, and schedule a colonoscopy if it's needed. Initial blood tests are done to rule out anything like anemia or infections, or like we talked about the CRP for inflammatory bowel disease. Look at thyroid function, stool tests are done. Sometimes additional tests for celiac, for bacterial overgrowth in the small intestine, which can cause bloating, and then stool tests for Clostridium difficile, or for amoeba, or for parasites, and then sometimes even CAT scan and MREs can be scheduled if needed. So moving on to inflammatory bowel disease, which is ulcerative colitis and Crohn's disease. This is a map of where it's most common, and if you look at it, the high prevalence is really again in the developed countries, like we did with IBS, and it's in US, it's a high prevalence. In some other countries, there is very low prevalence, although we feel that there might be an increase because of increase in certain increased use of antibiotics, which then changes the flora. A change in the diet when we are moving on to more refined diets and not sticking to healthy diets. Worldwide, especially in the past 8 months, the stress levels have gone up. Smoking causes an increase in Crohn's disease. Any kind of non-inflammatory medications, non-steroidal anti-inflammatory drugs like aspirin, Motrin, Advil, Aleve, ibuprofen, Excedrin can change the microbiota as well as the mucosa in the colon and reactivate or cause IBD, and acute infections, as we talked about in the slide showing how things change. What are the symptoms of IBD or inflammatory bowel disease? They can differ based upon whether we're looking at Crohn's disease or ulcerative colitis. Ulcerative colitis is predominantly a colon disease, so it affects mostly the colon or the large intestine, whereas the Crohn's disease can go from all the way from the mouth to the anus and can also involve other extraintestinal organs. Both ulcerative colitis and Crohn's disease can present with arthralgias or aches and pains in your joints, ulcers in the mouth, erythema nodosum, which is a disease of the skin, nausea, vomiting, fever. Some of the patients, when they have diarrhea, can have fecal incontinence, cannot control the diarrhea stool, pain. They can have skin lesions, skin ulcers. They can have jaundice because the liver gets affected. In children, there is growth retardation. And with Crohn's, you may see mostly non-bloody diarrhea, whereas in ulcerative colitis, usually you see bloody diarrhea with the urge to go, which is tenesmus. And a lot of times in anorexia, which is loss of appetite and weight loss, can be seen with both if there's severe disease. And we classify this as acute, severe, moderate, or mild, and the treatment differs based upon what kind of disease you have. The gastroenterologist will get a history, examine you, do the lab test, and then may do an endoscopy or colonoscopy in order for the test, like I said earlier, with the goal to induce remission, which is make you feel better, maintain that remission, which is the treatment, and then enhance your quality of life and avoid long-term toxicity of the medication. So give you the medicines that are best, avoiding any kinds of adverse events that might come across. And then there's preventive management, which includes immunizing you for certain hepatitis, flu, pneumonia, and then screening for colon cancer, because patients do get to be at increased risk for colon cancer when you have Crohn's colitis or ulcerative colitis. This is a very busy slide which tells you about mild, moderate, and severe disease and how we approach treatment based upon the location of disease. And I'm not really going to go through this, but if any of you out there in the audience has ulcerative colitis or Crohn's disease, you're probably familiar with some of these. And when it's very severe, sometimes patients need surgery. So we have something known as a step up, or sometimes it's inverted pyramid and we do a step down, and that's why these arrows. But again, this is very complex, and most of the time you're doing this individual patient treatment. We are very cognizant of nutrition, and we say avoid NSAIDs and opioid pain medicines because these can exacerbate some of the symptoms. You'll find that a lot of times patients ask, will the diet change or heal everything? And very recently, there were several articles in the medical journals, and you can probably Google a lot of it also. And this is taken from a Google search, whereas there's a diet in IBD, which if you have acute inflammation, you want to stay away from vegetables and stay away from food that can cause more inflammation. So there's no anti-inflammatory drugs, and then there's probiotics, which will give you a better microbiota in your colon, and that might actually help you. So you want to have a nutritious diet, you want to have an anti-inflammatory diet, and there are several diets that are touted online. There is a very good resource from CCFA, or Crohn's and Colitis Foundation of America, and they can also, there are chat rooms over there, and you can go online and find out diets that might help you. But we do not think that a specific diet actually cures inflammatory bowel disease at this time. Maybe in the future we'll have diets that will change the microbiota and that might be able to heal patients. We do know that stress can also exacerbate inflammatory bowel disease. A lot of the patients believe that when they're very stressed, they feel that their IBD acts up. There are studies back in about 10 or 20 years ago that looked at motor vehicular accidents, and patients that had those had IBD flares. Their symptoms were really increased. And we know that, the psychological and physiological interactions mediate stressors and disease process. These patients can have a poor health-related quality of life. They have increased psychiatric distress, more anxiety, more depression. They feel there's decreased interpersonal support, and when they feel that, they find that this disease also seems to flare up. And especially now when you cannot reach out to family and friends, the perception of having decreased support can help increase the symptoms, increases illness behavior, and there's greater reliance on passive coping with avoidance versus a positive plan to make sure that you have less symptoms, whereas if you have more reliance on passive coping, you get more IBS symptoms. So we look at IBD and IBS as an overlap syndrome, an enigma wrapped inside a puzzle. You can have IBS symptoms after IBD remission. You can have post-infectious IBS or an IBD exacerbation. We know that the stress axis, hypothalamic pituitary axis, can activate and exacerbate both symptoms of IBD and IBS. We know patients with these diseases have increased visceral hypersensitivity. They blow up balloons in the esophagus and in the rectum, and patients with these diseases have more perception of that balloon being blown up than people that do not have these diseases or disorders. There's higher anxiety and depression and reduced well-being, more severe symptoms in both these diseases. Very recently, there was an article in The Lancet which showed that there's a high prevalence of IBS symptoms in patients with IBD. So what we aim for is to improve patient satisfaction and health-related quality of life, in addition to healing the inflammatory bowel disease and the IBS symptoms. Again, a constructive doctor-patient relationship involving the patient in the management, so you have shared decisions. You take away the pain. We know that you do not have cancer, and we can do tests, so we know that. We know that your symptoms are worse, so it may not be IBD, it may be IBS. If your symptoms are not getting better, we know when we need to change medicines. You're not crazy. What you feel is what the doctor actually validates. If you're under more stress, we know that increases the symptoms, and it does not get worse as you age. It actually is a function of how we treat it and how the stress is related and how the inflammation is controlled. So in conclusion, IBS is a prevalent chronic episodic medical condition. GI symptoms are characterized by abdominal pain, discomfort, altered function, constipation or diarrhea, several comorbid conditions. It can be caused by brain-gut interaction, visceral hypersensitivity, altered central processing, abnormal motility, or altered microbiome. IBD is also chronic but relapsing disease, which can be classified as ulcerative colitis, Crohn's disease, or indeterminate colitis. The symptoms are characterized by abdominal pain, diarrhea, blood and stool, mucus and stool, extraintestinal symptoms, sometimes IBS-like symptoms. They're caused by abnormalities in innate immunity, aberrant immune response to microbial antigen in a genetically predisposed individual. So an inflamed gut we know is irritable, and an irritable gut may also be inflamed, as we talked about that picture initially, where after acute infection, you can have mild inflammation, and that might lead to irritable bowel syndrome. So I thank you all for listening in or actually seeing the slides. And I know that Parminder and the staff is trying to get your questions in. If there were any questions, I'm happy to answer them. Please be safe. Please take all care. Maintain the distance, wear your mask, wash your hands. And if you have problems, please do come in because the offices are safe. Do not ignore your symptoms. And again, thank you.
Thank you so much, Dr. Chokhavatia. We do have some questions. The first one is it known why IBS is more common in developed countries? Is it because of diet, because of a diet of more processed foods?
So I can tell you that IBS, the prevalence that we know is increased in developed countries is partly because they may not have been the prevalent studies that have been done in certain other countries because they have other dire needs for diet, for other diseases, and mostly infectious diseases. And a lot of times they might have infection, and then a lot of times the diarrhea is a post-infectious IBS, and they just ignore it at times. Like I said, it takes up to even 7 years in developed countries to make the diagnosis. We know that it's more in women than men. We don't know if there's only one country, matter of fact, in India, where they found that the questionnaire that was circulated, the results were that there were more IBS prevalence in men. And then one of the theories was that maybe men presented to doctors more frequently. So again, go figure, right? Maybe it was male dominated, I don't know, but I know that overall there is a higher prevalence in women. And if we did more detailed studies in other countries, we might find that it's, maybe 12, maybe 20%, we don't know.
Okay, thank you.
The other part of it was with the diet, and we do know that certain diets, patients are more sensitive to diets, and that's why I brought up the FODMAP's diet. But like I said, again, use it as a guide. Do not get into being very avoidant and very restrictive with your diet, and especially if that's going to make you lose weight. It's something, if you're already below par, you don't want to lose more weight.
Okay, next question. What is tenesmus?
That's what I said, was like the urge to go. So when you have diarrhea, it's a medical term where when people have the urge to go and it's very painful, it's called tenesmus.
Okay. Differences between taking mesalamine versus sulfasaline?
So these are all 5 ASAs, and these are medications to treat inflammation. And this is very specific. So I would probably ask the person that called in with that question, the different trade names for different medications, and they might need to reach out to their physician to see why that specific 5 ASA was prescribed. Sometimes it's related to insurance coverage even. Okay. So again, good question, but again, it's very individual and it would be related to what sulfasalazine or, there is other medications that you can be prescribed. And these are all prescription medications, and you should definitely talk to your physician about it.
Okay, thank you. Can probiotic capsules increase or maintain the bowel flora as well as probiotics from food such as yogurt?
So again, excellent question. So probiotics from capsules are in much larger quantities. They're in the billions of colony forming units. So it says billion CFUs, and you get a more bacteria. Now, a lot of these bacteria can get killed in the acid in your stomach. So people that are taking, that are immunosuppressed or taking acid suppressing medicines, sometimes we say do not take too much of the probiotics also. The bacteria in the yogurt are actually naturally, added to the yogurt because, that's how it's fermented. So you get a lesser quantity. It's not in the billions, but it's good probiotic. And then in the foods, there's something called prebiotic, which means there are certain foods that can actually act for the bacteria, good bacteria to grow. And again, a lot of the fiber that we eat is maybe a prebiotic that we could be taking in. So eating healthy fiber, eating lots of fruits and vegetables, making sure that you take yogurt if you're not lactose intolerant, or if you can't, some people hate yogurt, then taking a capsule would work as well. I hope that answers their question.
Yes, I have one more. How does hypothyroid affect IBS, IBD?
So with hypothyroid, sometimes the hormones do change the way that your bowels function. A lot of hypothyroid patients may have constipation. And so if you're constipated, there's usually stool that's left behind in the colon, and the bacteria will act upon it, and then they may cause more bloating and may cause part of the functional symptoms like IBS-like symptoms. Because it's an autoimmune disease, and IBS, we know IBD, inflammatory bowel disease, is an innate immunity issue. There might be coexistence of thyroid issues with IBD. So different ways in which it can impact IBS and IBD.
Okay, here's another one. Should we see a general practitioner or a gastroenterologist with these symptoms?
So initially, I would suggest always having a primary physician, because that person will then coordinate your endocrinologist for your hypothyroid. If you have heart disease, if you have diabetes, if you have other issues, hypertension, they can see if there's medications that are probably causing some of your problems. So you want to reach out to the subspecialist after you've seen your primary care physician, because they will tell you if there's something that's maybe a result of a side effect or something that's going on with your primary problem, like your primary disease.
Okay, one more. Is it safe to use Pepto-Bismol occasionally for management of IBS with diarrhea?
So again, very good question. Pepto-Bismol will not harm you. The only thing it does do is color the stool black. So a lot of times people worry about black stool because that means that there is blood in the stool, but Pepto-Bismol colors it black. So if you're having diarrhea and you think Pepto-Bismol is going to take care of it, it's absolutely okay to use Pepto-Bismol. But if you have diarrhea for a very long time or it's getting very severe, if you have never seen a doctor, then I would suggest at this time, especially because of the COVID, some of the patients do present with diarrhea with the COVID-19 infection. So do not ignore it. If you have symptoms that persist, please see the doctor.
Okay, thank you. Here's another question. Is there an inheritance factor in either one?
So we know for sure that with IBD, there are certain genetic predispositions and there's certain genes that make you more likely to have either Crohn's disease or ulcerative colitis. And with IBS, there might be certain genetic predisposition, certain inflammation that can happen. There are certain genes like TRP1, inflammatory changes that occur in the colon, but we don't know for sure if it is in fact genetic. So the inheritance really speaks to genetics, and IBS can run in families because we know that sometimes it's a learned response. So if the child sees a parent dealing with stressors, with reaction with either pain, gas, constipation, diarrhea, and avoidant behavior, they might learn that too. Like I said, with IBD, there is familial clustering, but that we know could be genetic. We know that there's increased incidence of ulcerative colitis and Crohn's disease, say in Ashkenazi Jews. So there's definite familial clustering there.
Okay, another question. Is SIBO a subset of IBS or its own disorder?
So we know that it's a great question. Again, SIBO stands for small intestinal bacterial overgrowth, because usually the microbiome is what we talk about, the bacteria in the colon. The small intestine does not usually have bacteria because it gets swept clean. So if there are bacteria in the small intestine, the food that we eat will be fermented before we absorb it. So in the colon, by that time we've absorbed everything. But in the small intestine, we haven't yet done the full digestive process. And that's when the bacteria act upon it and cause gas. So symptoms are gas, bloat, diarrhea because of the digestion not being completed. And it can be a different entity. However, we know that IBS patients do have an increased propensity to have SIBO. So whether there's a motility issue involved with that subset of IBS patients and therefore they have SIBO is one of the explanations. So the straight answer is it can be a separate issue of its own, or it can be a part and parcel of IBS.
Okay. All right, here's another one. Excuse me. Does the constant diarrhea affect the absorption of meds and supplements that one is taking?
Depends on which kind of diarrhea we're talking, because if it is more than 10, 15 bowel movements a day, then things are just going very rapidly through you, and that might affect it. But if you're describing diarrhea as 2 or 3 bowel movements after a meal, then probably not.
Okay. Okay. Triphala has been recommended to me from local health food store. Any thoughts?
No, neither. No great opinion on it.
Okay. Let's see. Do you know Narine probiotic? Do you think it will help?
I don't, but I mean, I would look to see what it's made up of. So you want to look at the constituents of what that probiotic has. Usual probiotic that I prescribe is Align, which has bifidobacter, and then lactobacillus, which is also in yogurt. So those are my go-to. And then, there are other prescription medications as well, but those you would probably talk to your doctor and they could prescribe them.
Okay, very good. And our last question for this evening, can problems occur from long-term use of Aprezo and Azokal? Is it meant to be long-term?
So these are long-term medications, and one should not go off these medicines unless your doctor tells you to. You might feel very good and you might want to stop your inflammatory bowel disease medication. However, these are lifelong diseases. We do not necessarily cure them. We know how to manage and treat them. So if you go off of it and the inflammation comes back, we know that there can be patients that are at increased risk for cancer because of the inflammation. As it's very important for patients with inflammatory bowel disease to be on a maintenance dose of these medicines. And again, if there are side effects, some people may have side effects with liver tests being abnormal. They should definitely take it up with their primary gastroenterologist. But these are medications that cannot willy-nilly be stopped.
Okay, thank you so much, Dr. Chokhavatia, for your wonderful, informative presentation this evening. We do appreciate